So again, in this quick 40-50 minutes, I will try to sum up with all the salient points and informations you need to know about the gallbladder pathologies, especially the acute cholecystitis, the acute inflammation of the gallbladder. And in the etiology, we will see that what are the risk factors and what are the pathophysiology, and how we can diagnose and how we can manage. And in the last, we will briefly touch upon the recent advances in the management. So as I've just stated, it's very simple. Any itis, we know that it is inflammation. So acute cholecystitis, acute inflammation of gallbladder, just to remember. And we will look into that when we talk about gallbladder. I think we should be very clear about its anatomy, its position, and in relation to the surrounding structure. So I'll quickly go through just a recap from the initial years of MBBS, the anatomy, and you all can appreciate if we isolate the gallbladder and we see it in isolation, it is a fundus. Neck. And then this cystic duct joins the common hepatic duct. The cursor is at right this point, which actually proximally going towards this Y, the limb of the Y, the hepatic ducts, the right hepatic duct and the left hepatic duct, draining the right and left side of the liver. So from the porta, the right and left hepatic duct comes out. A very common name is Keller's triangle, which everyone talks about. So I think it is also important for you guys to know about the Keller's triangle. So journal look, if we sketch out, this is the inferior border of the liver and the gallbladder bed where the fundus is projected. Superiorly inferior border of liver. Inferiorly, it is the cystic duct, and medially, it is the common hepatic. So, is like this. And actually, the cystic artery is the content. In detail, that how hepatic duct, the common hepatic duct, they join with the cystic duct and form the common bile duct. And then in the from the medial side of the second part of the duodenum, the common bile duct we can appreciate the major duodenal papilla on which the common bile duct and the major pancreatic duct. We know that there are two pancreatic ducts. We are not going into detail. Sometime, inshallah, we will study the pancreas as well, acute or chronic pancreatitis, and then we will Thank you. Thank you for letting me know. So we were just talking about the etiology, and now we just looking at the slide of the risk factors. When we were students, we were generally told by the seniors that the 4 or 5 Fs should be remembered for the cholecystitis, and again till this time, uh, much of the etiology and the risk factors are same. That is, the first F is 40, and then the female gender, and the obesity, that is fat, and in female, the multiparity, that is fertile. May I request the participants to please keep their mics mute? Thank you. So, familial, and is the fifth F, the family history. And additionally, the recently identified factors may be the rapid weight loss, because this is indirectly turned related with obesity, that when people try to reduce weight very rapidly using multiple medicines or crash diets, the rapid weight loss may cause gallstones and can precipitate acute cholecystitis. Physical inactivity, dietary habits, these all are interrelated factors which actually come up again to these 5 Fs. And oral contraceptives to the females, and then multiple other factors, the genetics are involved. So far, if any question, I would be happy to address. Otherwise, we can take and discuss at the end. Okay, so now in the next 4 or 5 slides, I will discuss the pathophysiology of the acute cholecystitis, that how it starts and how it progresses. In stage 1, when because of all the factors I have just narrated, if by any reason the stone has formed, at the first stage, the sludge and then the stone, if dislodges into the cystic duct, and on the stimulus of the food, when food enters from stomach to the duodenum, and we know that the stimulus goes to the gallbladder for contraction, the stone is forced into the cystic duct, and that causes mid epigastric colicky pain. And due to gallbladder contraction against that obstructed cystic duct, the gallbladder tries to overcome that obstruction and tries to push the bile into the duodenum as per the natural physiology. Then the severe pain occurs, and that pain then causes nausea and vomiting in patients of the acute cholecystitis. In stage 2, that dislodged stone, which from the gallbladder, fundus, and body and neck has traversed to the cystic duct, become impacted, and then mucus accumulates behind that obstruction, and continuous chemical irritation of the gallbladder mucosa occurs. And we all know that wherever there will be stagnation, there will be infection. Then bacterial oval growth occurs, which is most common organisms are E. coli, and less commonly Enterococcus or Bacteroides, or sometimes very rarely Clostridium can infect. So then this pain, the referred pain from the epigastrium, mid-epigastrium, shifted to the right upper quadrant. And that is a dull, continuous aching pain, because small contractions continues from the gallbladder in an attempt to overcome the obstruction. And then this pain radiates because of the nerve supply to the right scapula and shoulder tip. In stage 3, this bacterial invasion, which was initially just to the mucosa, penetrates, invade deep into the gallbladder walls. And there comes the point when localized peritonitis with rebound tenderness, when clinically examined, there will be localized peritonitis, tenderness, and rebound tenderness also. And then the positive Murphy sign, and we all know that the point when we touch the surface marking of the gallbladder, if we compress because of the tenderness of the fundus of the gallbladder, that is known as the Murphy sign. And when we look into the labs, we see the complete blood count, the CBC, absolute neutrophil leukocytosis we observe. And this attack subsides if stones falls off the cystic duct. Sometimes because of the size of the stone, or sometimes with the effort of the gallbladder, the forceful contractions, sometimes the stone which was impacted for some time in the cystic duct pushes out of the cystic duct and goes into the CBD. And this is another story we may sometime discuss, that cholecystitis, the stone in the common bile duct. So approximately, generally, it is said that 90% sometimes subsides over ensuing the mouth of the duct. And if not, if it persists, then the times come when over distension of the gallbladder and invasion of all the layers of the gallbladder walls occurs and gallbladder perforates. That is the stage 4. So in stage 4, what happens? Gallbladder may perforate, and the tension over the walls, because of the continuous compression and distension of the gallbladder, causes compression of the intramural vessels, and there comes another stage, that the necrosis of the walls of the gallbladder starts and gangrene occurs. So this is the stages like this. These are the gallstones once formed. They, with the contraction, when the food reaches here, they contract and sometimes they trapped here. This is shows in the cystic duct. And the process, the stage 2 and 3 occurs if these stones keep its position here, but sometimes with forceful contraction, it comes into the CBD. And there comes again a series of events. If the gallstone keeps blocking the CBD, then what happens? And but if we consider that sometimes it passes out, then the settlement of the acute cholecystitis phase starts. But if it persists, or if there are multiple stones, that one stone passes out, the settles, then again sometimes after interval another stone causes the same. So acute on chronic cholecystitis and chronic cholecystitis, inshallah, coming Sunday we will know about the chronic cholecystitis. So you can unmute or reply, or you can comment in the chat box that just to recap, that what is the most common cause of acute cholecystitis. We have touched upon many causes. So acute pancreatitis, cholecystitis, diabetes, maybe idiopathic or trauma. So I'll wait for the end and I'll look into the answers in the chat box. So how to diagnose the clinical finding? The patient may present with fever, and this depends upon also the stages of acute cholecystitis, that patient present to you early or patient present to you late, like after 48, 72 hours after the onset of the symptom. As I initially tell, the vomiting, the pain, the fever. So the triad. And pain has characteristic radiation to the right scapula, starting from the mid epigastrium and shifting to the right upper quadrant, right hypochondrium, and radiation to the right scapular shoulder. Murphy sign, I have just also told you guys, but again repeated, that on deep palpation in the right upper quadrant, there is a pain when inflamed gallbladder hits the examiner finger. We ask the patient to take a deep breath. You put your hand in the right upper quadrant, and when the patient takes deep breath and you push your hand, the fundus of the gallbladder comes in contact with the anterior abdominal wall and touches your finger, and patient will hold the breath because of the excruciating pain. Another finding, which in cases of obstruction can be observed, is the jaundice in 25% of the cases. And that is actually an indication of the common bile duct exploration, because it is indirectly telling you that there is some obstruction. And palpable gallbladder, if it is the chronically obstructed gallbladder and mucocele or porcelain gallbladder, stage has occurred, then you may be able to palpate the gallbladder. How to diagnose? Clinically, we have just discussed, and that what will be the symptoms and what will be the signs, and the lab help and radiology help. So in the lab, as previously said, that absolute neutrophilic leukocytosis with left sheet will be observed more than 12,000 per cubic millimeter. That is a very significant finding, and you will be observing this finding in your clinical practice in more than two-thirds of the patient population who will be presenting to you with acute cholecystitis. You should be getting LFTs in all patients with the suspected acute cholelithiasis causing cholecystitis, that their enzymes will be raised and their bilirubin will also be raised in cases especially of obstruction. Ultrasound is non-invasive and very helpful diagnosis. Right at the moment, it is considered as the investigation of the choice, and it is a gold standard test because 98% sensitivity. It will tell you about the presence of the gallstones. It will tell you about the status of the gallbladder wall. It will tell you about the pericholecystic edema. It will also tell you about any presence of the sludge. That is the initial stages of stone formation. And sometimes it is not very helpful if the stone has fallen into or slipped into the CBD. Then we need other investigations like maybe ERCP or MRCP. Plain X-ray films are also not very helpful, especially if the gallstones are cholesterol gallstones. The non-pigmented stones are generally not visible. If they are infective or pigmented gallstones because of any hematological disorders or infection, then this may be having positive finding. HIDA scan is another helpful investigation, and it may help you in identifying the stones, small stones in the cystic duct. And when you find no visualization of the gallbladder or no tracer into the duodenum, so that will indicate a stone in the CBD. This is, and again, thanks to the internet, I took this picture from the internet, that how it is performed, and intravenous immunodiacetic acid is given, and then by the gamma camera over the hepatobiliary area, the tracer, radioactive tracer is detected. And these two conditions, that if the gallbladder is not visualized or if no radioactive tracer is detected in the duodenum, in both cases it has its significance. Coming to that, if you have performed the HIDA and you think that there is no visualization of radio tracer in the duodenum, then this means that is obstructive jaundice, and it is an indication of CBD exploration, the common bile duct exploration for other than the cholecystectomy. You will definitely be going for cholecystectomy, but you will not stop here. You will also explore the CBD, so not to miss any stone in the CBD. So again, just I have put an MCQ, that what is the most common clinical symptom in patients of acute cholecystitis, what it will be: the abdominal pain, fever, jaundice, nausea, vomiting. These all may be present in the patient, but we want to know about the most common. So the patient presented with the symptoms, we have touched upon the symptom. We have discussed that what you should be looking while doing the physical examination of the patient, the signs you will elicit and you will observe. Then we discussed that how the labs and how the radiology will help you in diagnosing. And once you have made the diagnosis of acute cholecystitis, especially the acute calculus cholecystitis, the treatment is cholecystectomy. This is a debate in the literature that to what time period, we can wait and watch for asymptomatic calculus cholecystitis, but majority are agreed upon that the treatment should be cholecystectomy. And nowadays the laparoscopic is preferred, and we will just coming in the coming slide we will touch upon. So in the era of this non-invasive treatment modalities preference, ERCP with sphincterotomy is also an option available to extract the stone if it is in the CBD. In the drugs, mepridine for symptomatic treatment of pain, but it is not the permanent solution. It sometimes provide disadvantage to the patient because I'm talking about that do not use morphine, that it contracts the sphincter of Oddi, and that will further worsen the pain of the patient of acute cholecystitis. So mepridine is indicated for the pain, not the narcotic analgesics, especially the morphine. And we have gone through the pathophysiology that these patients generally develop infection. So the preferred choice of antibiotic should be given, and the preferred choice is piperacillin tazobactam, as we have discussed the spectrum, the E. coli and Enterococcus species. As I tell you that majority, the school of thoughts are agreeing upon surgical management, that is cholecystectomy, and open, laparoscopic, and robotic, depending upon the setup where you are working and which procedure you are well versed with minimal complication should be adopted. It's just not that the trend, what is the trend? Maybe people are doing robotic, but if you are not well versed with open cholecystectomy, don't opt for laparoscopic or robotic, because you may need to convert depending upon the findings. So in open cholecystectomy, again, in the start, I have talked about the callus triangle. When you open, even in the laparoscopic, when you enter, the first thing you need to is that you identify callus triangle boundaries and you do dissection. And the section steps is that you incise the peritoneum covering the cystic duct and cystic artery. You skeletonize, that is the anterior and posterior dissection, and you isolate both the cystic duct and the cystic artery. And in this maneuvering, when you grasp the fundus of the gallbladder and you give traction, the dissection on that cystic duct and cystic artery becomes easy because it gives stretch on the cystic duct. I have mentioned that you need to skeletonize, and then there comes the point that sometimes you may find aberrant artery or accessory ducts. So you need to clearly identify the course of the cystic artery, as well as identify and confirm that this is the cystic duct which is entering into the common bile duct. Otherwise, you may injure the surrounding structure, or you may miss some aberrant cystic artery which will bleed later, or you may miss the accessory bile duct which will keep on producing leak post-operatively. So generally the indications are, because the preferred method is laparoscopic, if you need to convert because of the failure, or large stones or ill-defined anatomy on laparoscopy, or on laparoscopy if some uncontrolled hemorrhages occurred, or the patient has compromised health and is intolerant of pneumoperitoneum, you need to create during laparoscopy. The procedure is done under general anesthesia with supine position, and you raise the thoracoabdominal junction by placing some roll behind the lower chest. And definitely you need to take informed consent from the patient as well as the guardian. And you need to mention, when we talk about the informed consent, informed means that you inform the patient about the possible complications which can happen on table, peroperatively, or post-operatively. So I have just summarized in the previous slide that what are the steps, and this is the summary again. and then you divide the cystic duct and cystic artery. You ensure about the hemostasis and drainage of the gallbladder bed, and you close. That is your choice, that you close the abdomen in layers, or you close the abdomen en masse with continuous sutures or the interrupted sutures. Coming to the laparoscopic technique, this is the preferred method nowadays, and indications may be the symptomatic cholelithiasis or the porcine gallbladder. Contraindications I have just mentioned in the previous slide. Additional to those, if you suspect some malignancy or dense intra-abdominal adhesions, you should not be going for laparoscopic. Then open is the preferred. Again, it will be done under general anesthesia, and again the informed consent with the mention of the risk factors should be ensured before the start of the procedure. Position again with the supine, legs apart. The table should be preferably breakable, that you should be able to apart the legs, because surgeon may stand on the left side of the patient, and some surgeons like myself prefer to stand between the legs of the patient, because that made me more easy, because monitor is on the head side, on the side of the anesthetist, which is who is standing on the head side. So right to the anesthetist, the monitor, and that helps the surgeon standing on the even left side to observe, and the assistant and the nurse position, and another monitor should be on the left side of the anesthetist on the head side to help the assistant and the scrub nurse as well. So these are the port position. One is the umbilical port, and nowadays the preferred SILS is another single port, also preferred, but multi-port is also in practice. And I would recommend that if you start, just the learning curve is like that, you should be starting with the 4 or even 5-port laparoscopic cholecystectomy, and these are the incisions, port size. Technique is again the creating the pneumoperitoneum. Generally in adult population, 10 to 12 millimeter of the pressure CO2 is created. Port placement I have just shown. Rest of the steps are quite similar as to the opens, that dissection in the callus triangle and identifying the structure, especially the cystic artery and duct, and then skeletonizing and clipping, and then dissection of the gallbladder from its bed. And extraction can be at your choice. Many surgeons remove from the camera port, that is the umbilicus, and some use the laparoscopic organ removing bags, and after ensure the removal of the gas and then the closure of the ports. Post-operative management, this also varies with center to center, but generally nil by mouth till bowel sounds returns, and till that time maintenance fluids are given. Patient is kept on analgesics and antibiotics for at least 72 hours, and general care, that is dressing and gastroprotective drugs. And in adults, DVT prophylaxis should be made, and the histopathology is mandatory. And if it is a calculus cholecystitis for which you have done cholecystectomy, send a specimen of the stones as well for the chemical analysis. As I have mentioned in the informed consent, the cholecystectomy, either open or lap, both carries the risk of post-operative bile leak, bleeding intraoperative as well as post-operative. Infection may occur, and this infection, the surgical site, the gallbladder dissection site, both can occur. Injury to the nearby structures such as the common bile duct or liver or the small intestine. Risk of general anesthesia, generally, which are the embolism or the pneumonia or the DVT I've just mentioned. So these should be kept in mind, as well as consult to the patient, and if the patient is minor, then the guardian or the caretaker. So this is the incidence. A safe surgeon should have minimal complication, because The cholecystectomy is an established procedure even now as lab cholecystectomy. So these complications should be minimum. As I have shared this table, the biliary injury of any of the structure like biliary channels, the common bile duct, the biliary leak, biliary strictures, because biliary stricture generally are more at risk during lab cholecystectomy because sometimes you catch hold of the duct while making dissection. Retained CBT stones, if you haven't have close look into the patient's signs, symptoms, and the scans, you may miss and you don't explore, and then there will be retained CBT stone. Post cholecystectomy syndrome is established syndrome in which indigestion to fat, persistence of the pain, and symptoms, other symptoms happens post cholecystectomy diarrhea. That is the flatulent diarrhea because of the indigestion of the fats, because bile is not stored in the gallbladder. So whatever bile liver makes is going into, but at the time of the need of the fatty meals digestion, there is no bulk from the which was previously used to be from the gallbladder. Vascular injury can occur, abscess formation. I have talked about the infection at the gallbladder dissection site as well as the surgical site, and bowel injury. So if we just finish with the key points of the laparoscopic, mainly the advantages that the small incision, improved cosmesis, early recovery as compared to the open cholecystectomy, because in open cholecystectomy you need to give large incision which is muscle cutting incision, and by the applying of the retractors during the surgery later on there is more pain, so less post-operative pain and reduced hospital stay in case of lab cholecystectomy. I would like to just touch upon the cholecystostomy, because when we discussed about the pathophysiology, we talk about that if the stone remains impacted for a long time and the pressure in the gallbladder builds but doesn't perforate, and you went into and you see that there is a mucocele or hugely dilated gallbladder, and there is quite advanced inflammation, there is edema and inflammation, infection of the area, and the anatomy is not very well identifiable, then the preference is that do a cholecystostomy, put a drain in percutaneous into the gallbladder, in the fundus of the gallbladder, and you make double purse string and you tag the fundus of the gallbladder to the under surface of the anterior abdominal wall, and you put a catheter in that, and that drains the gallbladder content for certain time for like 4-6 weeks, and then settles the inflammation and infective process, and later you get a contrast study through that catheter, and if things settle and with the help of the additional ultrasound, then you later go for the cholecystectomy, that is the elective late cholecystectomy, that is the definitive plan. As I mentioned that sometimes the stone slipped into the common bile duct, that is the cholecystolithiasis, and for that you may opt for the ERCP, or on table you perform exploration. Lastly, I would like to touch upon that the advancements, and that is the robotic. And like many of the surgeries, the robotic surgery is also at many centers, in advanced centers in UK, US, Canada, is cholecystectomy is also done by the robots. So robotic cholecystectomy. But this is also an area of the debate. Like in the last lecture of the inguinal hernia, we talked about the debate over the laparoscopic inguinal hernia, that the incisions, multiple incisions, are equivalent or rather more than the open herniotomy small incision. So similarly, the debate is still going on that should the cholecystectomy be done by robots or not. because there is not so far not larger patient series are available or the clinical trials for verifying the advantages of robotic surgery over the conventional surgery. So this, but you should be knowing that yes, some centers are doing the robotic surgery. uh, it is costly, it is time consuming, and its expertise comes after attainment of the full expertise in first the open surgery and then the laparoscopic surgery. Only then one can start learning for the robotic surgery, because the coordination while sitting on the console, this is the console where the surgeon sits and puts his or her arms in the console's arms, which then guide about these robotic arms. And this is the dock station, which is actually another very technically challenging and demanding, that before even the start, like the laparoscope, you launch this whole dog onto the patient, and you need to make sure the proper positioning of the robotic arms like the pores of the laparoscope. So this is quite cumbersome, and only with expertise in the first two stages of the surgery, then only you can come. And economy matters. I think we, the lower middle income countries, have yet time to go to the robotic surgery, though just for your information that even in Lahore, our two hospitals are performing robotic surgery, but definitely it is costly and time consuming as well. So I hope I have covered major key areas which are essential to know for you as student for acute cholecystitis, including the calculus cholecystitis. So I'm ending here, and I would be happy